AIDS came along, or HIV came along, people were looking for some way to make sure that the HIV patient was controlled as far as infection goes. You have to remember that when HIV came along at first, nobody knew how it was spread. Nobody knew who would contaminate whom. All we knew, or all the infection control people knew, was that it was spread from person to person. We knew it was spread through sexual contact, and that's basically it. We didn't know whether touching somebody would spread it. People were, if we had an AIDS patient, nobody would touch them. Some people wouldn't actually want to go over and touch them on the arm, or shake hands with them, or, God help me, actually give them a hug. Nobody, and I know it sounds stupid now, but that's what happened. So it then came out that it was spread by bodily fluids, not just sexual contact, but actually bodily fluids. So then the infection control people went overboard and said, okay, nobody touch anybody. And then they got a little bit more common sense, shall we say. So this is where universal precautions actually started to show its face. The focus, as it says here, was on blood and body fluids, the spread of which. Universal precautions is what it's known as now. So we treat everybody as if they were contaminated. You don't know who has HPV. You don't know who has hepatitis B, hepatitis C, HIV. So we treat every patient's blood and body fluids the same. Just like that. So this was another system, body substance isolation. Has anybody ever heard of that one? No, I'm not surprised. This was a sort of competitor, if you like, to universal precautions. So they decided that focused on isolation of all body fluids through protective equipment such as gloves. The one thing that the body substance isolation people said was if you wear gloves, you don't have to wash your hands after you take them off. Does that sound right? No. So it also addressed the transmission of non-body fluid associated pathogens. So most concepts were similar. Universal precautions focused primarily on blood and body fluids. BSI focused on the isolation of all moist body substances in all patients and referred to all patients and all body fluids. So they have been amalgamated somewhat. Hand washing was not required in the BSI system after removing gloves unless hands were visibly soiled or the gloves broke during use. Seems a little foreign concept to us now, but, well, many individuals did not like that fact. So it became a disadvantage of the BSI. So now we're left with universal precautions. I'll tell you a story. It was in Calgary, and it would be 1985. And we had a young gentleman who was extremely well known. He was a figure skater. And he was gay, and he was HIV positive. And part of having HIV, there is a particular lymphoma, which we'll deal with once we do lymphomas, which only shows up in AIDS patients or HIV patients. It's lymphoma of the brain. And as I said, this was about 1985-ish, there or thereabouts, when the HIV fear, I guess you would call it, was still in true. So we had to treat this young gentleman, and he came down with from the nursing unit with an IV, and he was on oxygen. He was in a wheelchair, but he was an IV and an oxygen. And the transporter brought him down from the ward, the unit, and he was all gowned and masked and gloved and, and we looked at the transporter and we said, "What's this?" And he said, "Well, the nurses told me I had to do this." So we had put on gloves simply because he had an IV up. And we apologized to him for the transport, and we took him in. We treated him. We got him back on the wheelchair. And I was the supervisor at that point, so I said, "Look, I'll take him back upstairs." What the hell, I'll take him back upstairs. So off I went upstairs with him. And to be met by these two nurses who were in gowns and masks and gloves. And I looked at him and I thought, "What the heck are you doing?" "Well, he's HIV positive." I said, "Yeah, but I've got gloves on because I've got an IV up. That's it." "Oh, that's what we want to do." So I wheeled him into his room, get him up, sat him on the bed, and he says, "Can you stop a minute?" I said, "Sure." So he stands up, gives me a hug, and starts to cry. And I said, and of course, being me, I start to cry too, but and he said, "I'm sorry." He said, you're the only people, downstairs people are the only people who treat me like I'm human." And I thought, oh, I have to go out of here and I'll start bawling. So I put him back in bed and off I went downstairs. And that's the kind of thing that happened at that era. And I'm talking about it and I'm thinking, that's a long time. It doesn't seem a long time to me, but it is a long time ago. And that's what happened with the HIV crisis when it started at first. So eventually I went to the physician who was in charge of him. And I told him, and he said, he swore. And he said, "I'll see to that." So I guess he went upstairs and tore strips off the nurses. But it's the kind of thing that happened. It really is. And that's why the artists like, oh dear, I can't remember his name now, hid the fact that they were gay, especially when the HIV started. He died of AIDS. I can't remember. Anyway, so that's just my story. So that's what the fear was there. It was really sad, but the fear was there. So nobody would shake hands with people who were known to have HIV.
Freddie Mercury.
Well, but he was later, well, slightly later. And they, I wasn't thinking of him, but yes. Anyway, doesn't matter. So this is the Occupational Health and Safety and Health Administration, or OSHA. As I said before, OSHA is one of the people or one of the areas that can shut a hospital down. So OSHA did the 1999 procedures to ensure uniform inspection procedures concerning blood and body fluids, or blood-borne pathogens as they were called. So the major features of universal precautions in BSI: standard precautions applied to blood, all body fluids, secretions, excretions, except sweat, broken or open skin, and mucous membranes. Standard precautions are designed to prevent nosocomial infections. What are nosocomial infections again? Pardon? Hospital-based infections. They're not so much hospital-based infections anymore. They were. It used to be that if you got these nosocomial infections or hospital-acquired infections, you didn't actually have them show symptoms until you got home. Nowadays, you have people in the hospital with MRSA and C. diff, which are actually nosocomial infections. Always practice standard precautions as if all patients have undiagnosed infections. So hand washing, obviously. As we've all heard by now for this pandemic, how do you stop it? First things first, hand washing. If I was really being super efficient, I'd show you how the correct way to hand wash is. I'm not going to do that because I think it's silly. But anyway, how do you wash your hands? What is the system that you wash your hands?
Take off your jewelry, take off your jewelry, turn on the water. Yep. You wet your hands first.
Yep.
And then you put soap on, you scrub for 20 seconds, rinse your hands, turn off the water with a paper towel.
Right, so theoretically, the way the nurses are taught to do this, you do exactly what you do. They take off all the jewelry, they wet their hands, put soap on their hands, usually, hopefully, without touching anything. So you have these ones that you have in the washrooms here where you stick your hand under and the soap comes out. And you wash your hands 20 seconds minimum, and you wash your hands. And then you have 5 towels, 5 paper towels. That's the way they're taught. Mm-hmm. 1 paper towel wipes one, another paper towel wipes the other, 3rd paper towel wipes back and back, 5th paper towel does here. It's a waste of towels to buy. That's the way the nurses are taught to do it. So, gloving. Everybody should wear gloves. Mask, respiratory protection, eye protection, face shield. Ignoring what's happening at the moment. If you're treating a patient who is a normal prostate patient, for example, who isn't coughing, isn't spluttering, isn't doing anything, what do you have on?
Just gloves, right?
Just gloves. Just gloves. If he was coughing a lot, then you'd wear a mask. Respiratory protection would only be for something like, as I said, ignoring what's happening at the moment, TB, something like that. Eye protection and or a face shield. So in some departments here, the staff is wearing face shields. In some departments in the hospitals, they're wearing goggles. Same thing. You're protecting your mucous membranes of your eyes. When would we need that? If the patient has probably a productive cough, or perhaps, like we said this morning, a trach. If the patient coughs when they have a trach, where does the cough come, where does the phlegm come out? The trach. So you're leaning over to put the mask on the patient who has a trach and they cough. Where does it go? Right in your face. So that's when you would do it. Gowns and protective apparel. So, gowns. When would you wear a gown? Protective gown. If the patient was bleeding, or if they were having diarrhea, something like that, that might go on your clothes, then you wear a gown. Patient placement. That's another reason why most people wear scrubs. There are some departments who insist that the staff wear street clothes and put on white coats. My opinion, that's silly. Because I've had clothes ruined that way. I've had people throw up on me, I've had people defecate close to me. It just isn't right. Anyway, it tends to get too warm when you're running around all day. So, scrubs. Transportation, patient placement. Okay, so this is if you have someone who is infectious, say they have C. diff, or they have MRSA, or they have shingles, or something like that. What time of the day might you treat them?
At the end of your schedule.
At the end of the day? Yeah. If you had maybe a break during lunch, if you were lucky enough to work in a department which had a lunch break, not many people do, but if you say you have a 12 to 1 lunch break, no patients in there, you could treat them the last thing in the morning. But then you have the problem if you run late, then you may not have time. So usually at the end of the day, whenever that appointment is, it could be the last appointment at 3:30, it could be the last appointment at 5:30, depending on what your schedule's like. So you always try to make sure that any patient like that is treated at the end of the day, the end of the schedule. And transport of infected patients. That can open a can of worms. Depending on what your definition is of an infected patient. An infected patient could be someone who has MRSA or C. diff. It could also mean someone who has active TB. It could also mean someone who has shingles. If you actually touch the skin of someone who has shingles, you can actually pass it on. So you have to be extremely careful. And you have to make sure that your bed is covered with a sheet. You put that sheet, once they're done, into the bag for infected linen. You scrub the bed down with what?
Bleach.
Bleach. And how long do you have to leave the bleach on? Pardon? Somebody?
Is it
Sorry, I thought I heard
20
somebody.
minutes?
Is it like 10 minutes?
10 to 15. You can squeeze out 10 if you are in a hurry, but the longer it lasts, the better. And you should actually let it air dry if possible. And then you would wipe it with water, just to make sure there's no bleach left on the table. But again, it depends on what your manufacturer tells you that you can use. But usually on these beds, bleach is fine. And that basically kills anything. Okay, patient care, equipment and articles. I think we've just gone over that. Okay, the laundry, obviously. Student routine cleaning of an environment. Now, as we said last week, the cleaning staff will come in, clean the floors, and that's it. They won't touch the bed, they won't touch anything on the counters. So you have to be in charge of that. And sometimes things get a little dusty. So you have to basically, I know it sounds strange, but you can dust the room. That dust the room usually. Because if you leave anything on the counters for long enough, it'll get dirty. You have to make sure you clean it because of cross-infection. You don't want to take a mask off that's been sitting there for a long weekend and it's got a little dust on it. So you make sure it's clean before you put it on the patient. Or a piece of equipment that sits in a corner and you don't use it for a couple of weeks. So you pick it up and the doctor wants to use it on the patient and you find a fine film of dust on it. So you have to clean it because the cleaning staff won't touch them because it's radiation therapy equipment. Blood or body fluid spills. Well, if it's a small, what does blood or body fluid cover? Obviously blood. What else does it cover?
Vomit, diarrhea.
Vomit, diarrhea. What else? Okay. Sweat. Phlegm. Spit. Whatever you want to call it. Anything that basically comes out of the body. Urine. The most common one, believe it or not, is urine. I know, it's gross, but you've got to do it. So the patient's lying on the bed and he pees on the bed because you can't hold the bladder anymore. Doesn't tell you until you come in. So you think, okay, so you send him out with a pair of scrub pants so that he can get home in a pair of dry pants. So what do? Do you call the cleaning staff? Do you call the environmental control? Environmental services? No, you don't. If he had an accident in the bathroom, for example, yeah, you might just do that. But in the treatment room, on the bed, no. So you use bleach, you put gloves on, you clean it up. And you put whatever you need to, whatever, whether you use a cloth or a towel or whatever it is, you put it in the laundry basket for contaminated linen. And if you use paper towels, they go in the contaminated pile as well. I think the worst one I ever had was somebody who, we were treating them and the machine was underneath him at 180 degrees and he peed on the bed and went right into the machine. So we had to make a weird phone call to our physicist. And we have a problem with our machine. What's wrong with it? Well, somebody peed inside. How the heck did they do that? Well, you see, the machine was at 180 and the guy peed and it went through the bed and down into the head. So they basically had to take the machine down for a half day and clean it out. That wasn't popular with anybody. However, so student education. When you go into a clinical site, they will expect you to know what we do for infection control, what you should do and what you shouldn't do. What do you think is the most common mistake that people make when treating patients as far as infection control goes?
Not cleaning their hands.
Pardon?
Not cleaning their hands.
Not washing their hands, yeah, or cleaning their hands, yeah. The worst one we've found in my years of teaching students is that they forget to change their gloves. They wear gloves, but you're supposed to change them after every patient. You don't wear the same pair of gloves throughout the day or throughout the morning because you take them off to eat, hopefully, take them off to eat. So they wear a pair of gloves in the morning and they wear a pair of gloves in the afternoon. That's just as bad as not wearing gloves at all. Because then if you're handling the patient with your hands, then you at least wash your hands afterwards. But if you wear a pair of gloves, well, you don't need to wash your hands because you've got gloves on. The other thing is that the pens that we put marks on with, the same pen is used for every patient, which is a no-no. Now, having said that, there are some departments who will and are still using a pen that people keep in their pockets, and they take it out and they put marks on the patient, put it back in their pockets, and then mark on the next patient. That is a no-no. We shouldn't be doing that. However, if you see somebody doing that, please report it to me, not to them, because that obviously is what is done in that department. And a student shouldn't be telling them that they're doing something wrong. Does that make sense? Because you don't want to get off on a bad foot. So basically you want the basics. You want what HIPAA says, what OSHA says should be done. And that's part of what should be done. So, HIV and AIDS, acquired immunodeficiency syndrome. 1981 was the first patient. HIV first case from occupational exposure was 1983, and that was from a needle stick. At that point, we didn't have those fancy needles that lock. You had to recap, but you shouldn't recap. You never, ever, ever recap a needle. You put it in the sharps box, which should be there for you, without the cap. Put the cap in separately. So this is, since 1983, we've been going on about these needle stick injuries. Preventing exposures to blood and body fluid is a primary way of preventing occupational HIV exposures. 84% of job-related acquired HIV. That's the other percentage is probably mopping up blood or something. But 84% of the occupational exposures to HIV was 84%. And as I said, there is no reason for a radiation therapist to ever recap a needle. No reason whatsoever. Seek care quickly, immediately, report an accidental needle stick or body substance exposure. Seek care quickly because time is a factor. So if you're not wearing gloves and you're dealing with blood and body fluids, any little cut should be covered. So I have a scrape here in my hand. If I was doing clinical, that would be covered. With a glove, probably, I'd wear gloves, even if I didn't need to. Anywhere in the department, because you could have someone who looks healthy enough and fall down and crack his head open and have blood on the floor. So, yeah. Oh, I was going to, hang on a minute, I was going to get something. Talk amongst yourself for 2 minutes. So you remember me talking about pocket masks?
Oh yeah, I have one of those.
Yeah. So what kind of pocket mask do you have? The big one? Or the little one that sits in the key ring?
I have the big one.
The big one?
Yep.
Like this?
Yep.
Anybody else have one of those? I suggest you get one.
It's in my car.
So what these are is, I can get it on. Is a mask. So if you have to do CPR on somebody, you should have a pocket mask, similar to this. This is just a pair of gloves. They sell them at the bookstore, these things. But if you're going to be, in healthcare any length of time, you should have one of these and carry it with you. I have one in my bag and I have one in the office. Because if you're doing CPR and you're doing mouth to mouth,
I can throw up.
yeah. you need something like this. You don't want to do mouth to mouth these days without a barrier. Make sense? When they were teaching you CPR, did they use these ones?
We were taught about them, yeah.
I got one actually when I did CPR in the military, but I didn't
Yeah.
do it through American Heart Association.
No, that's fine. So they talked about them, but they didn't actually show you how to use them.
Because of Corona, they gave us smaller ones.
Oh, yeah.
Yeah, and
Yeah.
they gave us ones to take with us, but not like those.
Okay, no, that's fine. So this one is really good, just in case. Just in case. So, that sort of stopped my train of thought, I have to go and get that now. Okay, so, yeah. So if you're doing CPR, you need one of these. If you're in healthcare, I'll put it this way. If you're in healthcare and you're walking through the halls of the hospital and someone collapses in front of you, are you mandated that you should stop and help them?
Yes.
Okay. So if you're walking out of the hospital and walking across the parking lot and you're just outside of the campus, outside of the parking lot, and someone drops in front of you, are you mandated to help them?
You're in scrubs.
No.
Oh.
If you're outside of your hospital, if you're not on hospital property, you are not mandated to help. You probably will, but you're not actually mandated to help. But if you're in hospital and somebody drops in front of you, you are mandated to help. I was just showing them the mask that I was talking about last week. Okay. So that's just a little aside. I think most people in the healthcare profession would stop and help no matter what. As most of you know, I talked about my husband, who is many things, including a paramedic. And we were in a place called Banff, which is just outside of Calgary. It's in the mountains. Anybody know that one? No? Okay. So we're walking down Banff Main Street, and this gentleman, we looked across, and this gentleman fell, or collapsed. And Tom says, call 911, I'm going over to see if I can help. So he ran across the street, and the guy needed CPR. So Tom gets down and starts doing CPR. And then this gentleman comes up, and he's Japanese. And he has maybe 3 or 4 words of English. So the pair of them are doing CPR together. Tom's counting in English, the other gentleman's counting in Japanese, and the pair of them are doing CPR. And then they switch. And that went on for about 10 minutes till the ambulance arrived. And they picked him up, and he and Tom exchanged cards so that they knew who each other were. And they actually send postcards every so often. But that's the kind of thing that happens, is if you know CPR, it's basically international, even if you don't know your own language. Anyway, that's basically. Central Services Department. Accountable for preparing, processing, sorting, and distributing medical supplies and equipment required in patient care. So the CSD has to abide by stringent levels of quality control according to the Joint Commission. That's the other people who can shut a hospital down. So sterilization. What's the most common form of sterilization in a hospital? It all goes to infection control, right? Anybody? Are you just,
I'm stretching.
you're stretching, okay. Is that, sorry? What's the most common form of sterilization? Heat?
The autoclaves, are they heat?
Well, autoclave or heat, yeah. But there are certain things you can't autoclave. So, sterilization is a process that destroys all microbial life forms. This can be achieved through chemical or physical processes. Disinfection is a process that reduces microbial life forms, range from high-level disinfection to medium level, low level. Some microbial life forms cannot be eliminated by the disinfection process. So, heat. Moist or dry is the most reliable, available, and economical in destroying microorganisms. It's cheap. Gas. Available for medical products that cannot withstand high temperatures such as endoscopes and plastic items. Radiation, not routinely used in a healthcare setting, but widely used in commercial industrial sites for medical products. And chemical liquids, used for sterilization and disinfection. So those are the 4 types of sterilization that you may use. Autoclave is the heat. And then you have gas, radiation, and chemicals. So you only use certain things for certain. A lot of the stuff from Central Supply is only used once. So there are certain things that could be sent back to redo, like endoscopes, like our some of our equipment. Internal eye shields, for example, eye shields, things like that have to be sterilized. A lot of them can go through the autoclave, but some of them can't. Okay, so let's see. Let's try this one. Okay. Okay, so this is the kind of weird part of it. Much unnecessary harm is caused by healthcare errors and system failures. Hospital-acquired infections from poor hand washing. You would think that hospitals would know to make sure that their staff knew how to wash their hands. And they do. But being human, some people either don't wash their hands or don't wash them correctly. Physicians, for some reason, are the worst culprits. That sounds weird, I know, but they are. Example 2, complications from administering the wrong medication. Yeah. Well, that isn't actually infection control, but it can harm the patient. Prevent or eliminate the adverse effects and eliminate preventable harm. So, according to WHO in 2005, 8.7% of hospital patients suffer from what they call here healthcare associated infections. 8.7. In developed countries, 5 to 10%. In developing countries, 2 to 20 times higher. Nosocomial infections, that's the health-associated infections, may affect more than 25% of patients. That is, they call that significant, I call that terrible. I call it atrocious. At any one time, over 1.4 million people worldwide suffer from infections acquired while in hospital. And we're not talking in some cases, we're not talking the hospitals that are basic. We're talking university hospitals, people who should know better in healthcare that are equal to any healthcare that you would get in the Western Hemisphere. So HAI, or nosocomial infection, is an infection acquired in a hospital by a patient who was admitted for a reason other than that infection. So a patient would not be admitted for C. diff or MRSA, but they're infected with it while they're there. They may have cancer, they may have a hip replacement done, they may have anything, but they acquire this MRSA or C. diff while they're there. That's what an infection is. Or an infection occurring in a patient in a hospital or other health care facility in whom the infection was not present or incubating at the time of admission. That's something that we have to deal with, unfortunately. I won't say you will always get someone with a MRSA or a C. diff, but it's sometimes usual to have at least one patient that comes down with something like that. So of course, they can increase the patient's suffering, lead to permanent disability, lead to death, prolong the hospital stay, definitely, increase need for a higher level of care, and increase the cost to patients in hospital. So think about it, you come in for a hip replacement. Little old lady comes in for a hip replacement, and she develops MRSA, for want of a better phrase. So how long do they normally keep someone in a hospital these days for a hip replacement?
Probably not long.
Not long, probably 48 hours maybe, and then they get shunted off to maybe home or maybe to a skilled nursing placing. But if they have MRSA or C. diff or any of the others, they have to stay in hospital. So how much does it cost? Anybody have a fair idea to keep a patient in the hospital for a day?
$3,000 to $8,000.
Yeah, it's expensive. So it costs the patient through their insurance company. It costs the hospital because they can't get another patient in that bed. And if they have to move them to a higher level of care, which means if they're in a post-surgical unit and they have to go into ICU, then that costs a lot more for both the patient and the hospital, because the higher level of care from nurses and the physicians costs more. Requires healthcare providers who have knowledge of common infections and their vectors, an attitude of cooperation and commitment, and skills necessary to provide safe care. So knowledge of the extent of the problem, knowledge of the main causes, modes of transmission, and types of infections. So you have to be able to say, okay, I'm going to prevent these nosocomial infections. Apply universal precautions. Always. Use personal protective methods. We have all heard of the PPI. Personal protective, or PPD. Personal protective devices. Use them if you need to, if you have them. If you don't have them, get them. Ask for them. Know what to do if exposed. What do you do if you're exposed? Tell me.
Supervisor?
Pardon?
Tell your supervisor?
Yeah. You have to let somebody know. Encourage others to use universal precautions. You have somebody who is kind of lackadaisical about putting on gloves, doesn't want to, you can't do your job properly if you're wearing gloves. That's bull. You have to encourage them or threaten them. No, you don't threaten them, but you know, if the infection control person comes around, the nurse comes around, and you don't have their gloves on, ooh, you might get written up. And that is not a good thing. Report breaks in technique that increase patients' risks. Observe patients for signs and symptoms of infection. So report breaks in technique that increase patients' risks. What might they be? Breaks in technique. So we
Taking
all know-
shortcuts.
Sorry?
Taking shortcuts.
Taking shortcuts. What would you suggest would be a shortcut?
Like not properly washing your hands. Like
Yeah.
not washing it for the amount of time.
Not washing them, yeah, or just skipping to wash them, yeah. You've got the sink there, you've got the gel outside. There's no cause for you to miss. Even if you don't want to wash your hands, you use the gel outside, it doesn't take that long. Except if you have little cuts on your hands, then you have a problem, because it stinks like dickens. And observe patients for signs and symptoms. Normally, if you have someone that's difficult, then they may be in the hospital anyway, so. Protect yourself. Immunized against, okay, hepatitis B. Of course, everybody now is immunized against hepatitis B. But there are some departments that will let you opt out. There are some hospitals that will let you opt out. You have to sign a waiver form. Okay, person to person, okay, main sources of infection. Person to person via hands of healthcare providers, patients and visitors. So you have a patient in the room. The nurses are doing their thing properly. The therapists are doing their thing properly. But what happens when the patient is in his room, in the hospital, and has visitors coming, family, friends coming in? And what happens? They don't use universal precautions. Have you ever been, apart from, I keep saying this, apart from what we're doing these days, if you've ever been to visit somebody in the hospital, have you ever put on gloves to go see them? No. There are some people who, if say their elderly mother is in hospital and they're available, they can maybe come in and help the nurses do basic things. Perhaps, like maybe wash their face or brush their teeth or whatever they happen to do. That is actually nursing duties, right? But maybe the daughter does it for mom because the nurses are a little busy and what have you. So she should put gloves on if she's doing that kind of thing. But I can probably guarantee you she won't. Because she doesn't know. And she's never been told. So that kind of thing. They also bring in fruits or flowers or whatever it happens to be. All of that. Obviously the fruit should be washed beforehand. But flowers, plants, you see them still up on the nursing units with flowers and plants, and they're sitting by the bedside. You look pretty, but don't let the infection control nurse see them. Personal clothing and equipment, for example, stethoscopes and flashlights. Where do the doctors usually have their stethoscopes? Round their necks. Some of them will put them in their pockets, but normally they're around their necks because it's easier to get them off from their necks. Do they swab them before they use them? No, unless they've done it beforehand, but you never see them do that. What about clothing? Doctors never wear scrubs unless they're in the ER or the trauma center or in surgery. They usually wear street clothes with a white coat, right? What does infection control say about that, do you think?
What do they suggest? Do they suggest that the doctors wear like gowns in between patients?
The majority of the infection control nurses would have everybody in scrubs. And if the patient has got C. diff or has got MRSA, then they would have gowns. You may have noticed, or you may not, that most physicians now don't wear ties, even if they're wearing street clothes. They don't wear ties. Any ideas why?
Because they hang down and stuff.
They hang down again and stuff, yeah. They're an infection waiting to happen. Because who dry cleans ties? I mean, your suit, if they wear a suit or even a shirt and pants, they can be either washed or dry cleaned. Nobody dry cleans ties. So most physicians have stopped wearing ties. And anyway, they're a safety hazard as well, because I've seen somebody almost strangled by a tie. Patient grabbed hold of one of our physician's ties and pulled because he wanted to whisper something to him, and he just grabbed him by the tie and pulled. It wasn't pretty.
People are so weird.
What?
People are so weird.
Yeah, well, these things happen. Okay, environmental contamination. So what do you think that would be? Environmental contamination, actually we just talked about it. That would be the flowers and the potted plants and that type of thing. Not to mention the floors. You'll notice that some people, have you noticed the little thing that looks like a small Zamboni that goes around and polishes the floors? Have you seen that? I guess not. Yes?
Yes.
Yeah. So that kind of thing. Or they'll bring vacuum cleaners in to vacuum the floors. All of that kind of thing is environmental. Airborne transmission. So that's when you actually need the masks. Hospital staff who are carriers. Well, they shouldn't be there to start with. If you have C. diff or bursa, you shouldn't be working. But if you don't know, then you don't know. Common source outbreaks, so that would be
Cafeteria meatloaf.
cafeteria meatloaf.
Awful quick.
Yeah, okay, yeah, whatever. Cafeteria meatloaf. Okay, so WHO. What does WHO stand for?
World Health
Yeah,
Organization.
World Health Organization. So clean hands or safer hands, so the Campaign Centers for Disease Control and Prevention, the CDC, Prevent Antimicrobial Resistance, and Institute for Healthcare Improvement, 5 Million Lives Campaign, Developing Country Focus. So main routes of infections, UTI. Catheter-associated UTI are the most frequent, accounting for 35% of all HAIs. Catheters, urinary catheters. Why do you think urinary catheters, and we will get patients with urinary catheters in the department, why do you think those are most common infections?
You have a lot of bacteria down there, and when they insert that catheter up, they're pushing it up into your
Yeah.
body.
Or it could be that whoever actually inserts it in.
That bacteria.
Yeah. Now, nobody in their right mind would do a catheterization without putting gloves on. But they still have the problem of actually, they're sterile, these catheters. So you have to get them out of the packaging and get them into the patient without getting any microbes in. Everybody knows that urine is sterile until it hits the open air, right? So, and then surgical infections. Now, we don't see a lot about surgical infections in radiation therapy, but occasionally we'll have somebody who we're about to start treating, and we'll get a phone call saying their site hasn't closed yet because it's infected. And we cannot treat an open wound. For example, if we had a patient who just did surgery on the abdomen, and we were about to treat that area, and then we got called and said, look, his wound hasn't closed because it's an infection. We have to work on that. So surgical infections are another thing. So you would think that if anything should be sterile, it should be the OR, right? Because that's where they do all the surgeries. Aren't they supposed to be sterile? So how come 20% of all HAIs come from surgical infections? Someone's screwing up somewhere. Bloodstream infections associated with the use of intravascular device, about 15%. So that would be something like doing a stent, putting a stent in, something like that. That would amount to 15%. Things not still not working. Okay, well, let's try this. Oh, there we go. Okay, so 15% of all HAIs for something like a stent. Oh, sorry. And pneumonia associated with ventilators. Now, ventilators have been in the news a lot these days. Because of COVID-19, if they get really bad and they can't breathe, they go on ventilators, right? And it is well known that if you go on a ventilator, there's a certain percentage of the population who will not survive being on a ventilator. It's just one of these things. So if they can avoid putting on vents, that is much better for them. Because ventilators tend to introduce pneumonia or other infections. And being on a ventilator can kill you. So it's better if we don't put people on ventilators. So here is, and you can see the difference. The urinary tract well outshines everybody else. So 4 ways to prevent. 4 ways to prevent. So maintain cleanliness at the hospital. Personal attention to hand washing before or after every contact with the patient. Use personal protective equipment whenever indicated, and use and dispose of sharps safely. So maintain cleanliness of the hospital. Well, that's sort of outside of your control. That's outside of any of ours control. That has to do with the people who run the hospital and maintain the hospital, and the environmental services who clean the hospital and make sure that the airflow is good and the airflow is clean. Has anybody ever heard of sick building syndrome? No? Nobody's ever heard of that? It originally started when everybody thought it was a good idea to have air conditioning and heating and seal the windows so that we didn't have bugs coming in, or not bugs, flying bugs, but infections. So they sealed all the windows and used air handling devices so that they could keep the air moist and it clean, and the heating would be clean and everything would be clean. Unfortunately, it backfired. So now they found out that the air conditioning and the heating system can actually produce its own bugs. So now it's great if you can open a window. You can't actually in this building, but it's nice if you have somewhere where you can open a window, or you can get something like that. So that's what they call sick building syndrome. Personal attention to hand washing before and after every contact with the patient. Okay, so everybody's doing that, right? Do you think everybody's doing that?
No.
No. No. Everybody's doing that when someone notices they're doing it. The physician goes in, he washes his hands, talks to the patient, pats them on the hand, and so I've said, "You're doing fine, Mrs. Smith, I'll see you tomorrow." And they come out and they wash their hands before they come out, and off they go. And then they go into Mrs. Brown's room and they do the same. Because they've opened the door and shut the door, and now their hands are dirty again, supposedly. And they have to go in next door.
I had an IUD placed, and the only thing she did was use hand sanitizer.
The what?
I had an IUD placed,
Yeah,
and all she did was use hand sanitizer.
yeah. Well, I mean, a hand sanitizer is good for what it's supposed to be used for. But there's no, in my humble opinion, there is no replacing good hand washing.
Yep.
The hand sanitizer will not replace hand washing. It's good if it's there, but it's not excessively supportive. So in that case, that's not good technique. Personal protective equipment whenever indicated. Now, I know that at the beginning of the pandemic, there was a whole hullabaloo about people not having enough PPE. Nowadays, I think there's no such problem anymore, at least it's not to the same extent. So people are using PPE as it should be used. So there's no keeping masks for a week or having to keep your gown on for a week or something like that. It should be every day they should be changed, or every patient it should be changed. And the use and dispose of sharps safely. Of use and disposal of sharps safely. So anything that has a sharp edge, you put in the sharps box, which are bright red, and it says sharps on them. So you use it, you do a tattoo with a needle, you put it in the sharps box. No radiation therapist should ever have to recap a needle. And I've seen some people do that, but not much anymore because you have that special needle now that you don't have to. But yeah, you should never have to recap a needle. So studies show infections are minimized when hospitals and or clinics are visibly clean, use increased levels of cleaning during outbreaks, and use hypochlorite and detergents during outbreaks. So the outbreaks of COVID in hospitals or in work environments where they had to close the factory or close the store or close whatever it happened to be, a school, for example, because one person tested positive. And they cleaned the place within an inch of its life. That's the kind of thing that, unfortunately, it has to be done these days. But if you walk into a clinic, for example, or a doctor's office even, they should be clean, visibly clean. They should not have, as we sit on the upholstered furniture, they should not have upholstered chairs. They should have chairs that are clean easily. They should not have carpets. I went into a clinic to see a student just before the pandemic hit. And they had a beautiful waiting room there for a while. And it was beautifully carpeted and everything looked wonderful. And then I went in about 10 days before the pandemic hit. And it was wood. The waiting room was all wood. So I was speaking to the chief therapist and I said, so what happened to your waiting room? I mean, it looks nice, but you had carpet down. And he said, yeah, we had a little accident. And I said, okay. And I said, what happened? And he said, oh, someone took a dump in the middle of the floor. And I said, you're kidding, right? And he said, no. It was, shall we say, not the best part of town. and they had a homeless person come in looking for food and or something to drink. And of course they wouldn't give it to them, so he sat and had a dump in the middle of the floor and walked out. Yeah, yeah. Talk about infection control, yeah. Okay, but you know, this kind of thing, I mean, all joking aside, it was kind of weird. But that's the kind of thing that you have to do. You shouldn't have carpet in a healthcare facility, put it that way. You should have flooring that, like this stuff, that's easy to clean. Hand washing, most important. Intervention before or after patient contact. Requires knowledge and skills how to clean your hand. Rationale for choice of clean hand practice. Technique for hand hygiene. Protect hands from contaminants and protect adherence to hand hygiene guidelines. We had, when I worked in California, we had an infection control nurse that really was the limit. She was definitely anyway, she had one of the managers check how often we washed our hands. So she'd be standing there watching us while we came out of the room, and either we used the gel, or if we didn't use the gel, she'd come up and say, "Didn't wash your hands." I said, "Wash the inside. There's a sink in there. We washed our hands there." "Well, I didn't see you." I said, "No, because you're not in the room. We were in the room." So how to clean your hands, rationale. So you have to be able to tell whoever asks why you use the gel and not wash your hands. What would be your rationale for using gel as opposed to washing your hands?
Sink's contaminated.
Pardon?
If there's been something in the sink or if it's contaminated, some of those faucets and stuff I do not want to touch after I see something.
Well, the majority of the time nowadays, you don't have to touch them. You just put your hand under and they start. And the same with the soap. You put your hand under and they soap. But if you turn on the faucet and wash your hands, then you're washing your hands, so it doesn't really matter to begin with. It's turning them off that causes the problem, right? So what do you do to turn the faucet
Paper
off?
towel.
Use your towel, yeah. So if it's contaminated, yeah, sure, that's a good thing. But is there any reason why you should not use hand gel?
If you're like soiled from the patient or something.
Yeah, so if your hands are visibly soiled, of course they shouldn't be because you're supposed to be wearing gloves. But if your hands are soiled from anything, then you should not use the gel, you should use the sink, use soap and water. It's much easier, much better. And of course it says protect hands from contaminants. Well, you're wearing gloves. That's keeping your hands out of the way. So what about, we were mentioning earlier about jewelry. So I've got a bracelet and a watch on. If I'm physically washing my hands, I take my rings off. What about my watch and my bracelet?
Yeah, anything on your hands.
You take your watch off, definitely. And the bracelet, this one doesn't come off, so. Anyway, so you certainly you should take your watch off. There's a lot of people don't. There's a lot of people don't even take their rings off when they wash their hands. which is a no-no, but at least they wash their hands. You shouldn't wear gloves, you shouldn't wear rings with gloves anyway, if you're actually clinical. Most departments will say, okay, you can wear a wedding ring or a signet ring, but that's all.
I just wear my rubber ring most of the time.
Yeah. You shouldn't really have anything that will catch the gloves or catch the patient for that matter. Promote adherence to hand hygiene. Five moments for hand hygiene. Before patient contact, which we all know, before an aseptic task, after bloody or body fluid exposure, even if wearing gloves, after patient contact, and after contact with patient surroundings. So if you go into the patient's room, if you're upstairs visiting her, you've treated her earlier in the day and you wander up and say, how are you doing, type thing. And you put on your gloves, or you don't put on your gloves. Let's say we don't put on our gloves because we're just in visiting. So you open the door, you go in, you sit down, and you pat her on the hand and say, how are you doing? Fine. And then you put your hand on the chair and get up. You're contaminated. So you go outside and you wash, or you wash your hands inside and do that. Does that make sense? Okay. That's patient surroundings. Okay, there's your fun one. So before patient contact, obviously this guy has a catheter, has an IV in, has a catheter bag. So, anything you're going to do with this patient, he's needed downstairs in radiation therapy for his treatment. So you get him out of the bed into a wheelchair. You have to help him with his catheter bag and his IV. So therefore, you need gloves on. How to clean your hands. Okay, let's go for a break. 20-minute break. So back here at quarter two.